Okay, well, as I say, welcome everyone to pediatric teaching for today. Last week we talked about the management of critical illness in children, and this is the second in that series, if you like, of teaching about how to manage common critical illnesses in children. And I hope you may have had a chance to look at last week's talk, but so today I wanted to talk about some more cases and go through how we manage them and how we have a system for managing critically ill children. Even when you don't have that many resources, 80 or 90% of what we do in managing critical illness is within our ability to do so. So I wanted to start with this case, and it's a child I saw recently, a 7-month-old boy who presented with lethargy and vomiting and seizures over the last 2 hours. His lethargy and vomiting had been for a couple of days, but he had just seizures for almost 2 hours. When he was seen, he was poorly conscious. He had an oxygen saturation of 88% and quite dusky or cyanosed lips. He had a tachycardia, so a heart rate of 190, and he had cold hands and feet. Now, before we go any further, the first thing we do in looking after any child with a serious illness is think about triage. And so if you were to think about whether this child would have, remember in triage, we think about, has the child got any emergency signs or any priority signs? If you find an emergency sign, then you stop and give emergency treatment. If you don't find emergency signs, you can go on to priority signs. But if you do find emergency signs, you should stop and give emergency treatment. So do you think that this child would have any emergency signs?
Yes, he does.
And
So
what do you understand? Yeah.
convulsion, some signs of shock, cold hands and feet, tachycardia.
Yeah, very good. Yeah. Okay. So that's within a very short period of time, we should be able to recognize that in a child, and we should be able to then provide the emergency treatment the child needs. Remember that the stages of management in any sick child should go through this type of approach. So triage first, then giving emergency treatment, then taking a more full history and examination. You always take a brief history when you're doing triage, but later you'll need to take a more full history and then laboratory investigations if needed, and then come to the main diagnosis or other diagnoses, and then provide full treatment, and then supportive care, then monitoring and discharge planning and follow-up. So they're the stages of management of any sick child. For the critically ill child, it's just the same. At triage, you take a brief history of the presenting problem. We knew that the child had lethargy and vomiting for 2 days, followed by seizures for 2 hours. You take the temperature and weigh the child. You listen for you think about the airway, the breathing, and the circulation. Okay, you listen for stridor or obstructed breathing, or look for signs of obstructed breathing. You look for cyanosis. For B, you look for cyanosis and signs of respiratory distress. So chest indrawing, which could be tracheal tug or intercostal recession or subcostal recession or sternal retraction. You can have chest indrawing in any of those areas. And then you check the oxygen saturation. Then you feel a temperature of the hands and the feet. If you feel the temperature of the hands and the feet and they're cold, like this child was, then that's very concerning. You should feel at the same time feel a pulse, so the radial pulse, or if I usually feel the hands and the feet, so feeling the dorsalis pedis pulse or the posterior tibial pulse. You check the pulse volume, so it's a good idea to feel the hands and feet of a lot of children so that you get used to feeling at different ages and different conditions that children have, what the pulses feel like. It's very important to be able to feel the pulse volume and gauge, assess whether the pulse volume is normal or low or bounding. And then you check the capillary refill time. And when you put all those things together for what the hands and the feet feel like, what the pulse volume is like, what the capillary return is like, you can make a good assessment of the circulation. And if you can also do a blood pressure, then that's even better. All right. And then so that's circulation. And then for D, you assess for lethargy, and the level of interaction. D is for disability, but assess for lethargy and the level of interaction. And we know from this child was poorly conscious, had signs of shock with a very fast pulse, had oxygen saturations that was 88%, and signs of respiratory distress in terms of cyanosis. Right? The only thing the child didn't have was stridor. So this baby would need very strong emergency treatment. When we think about the possibilities in this child, I want to go back to the original problem. So lethargy, vomiting, and seizures for 2 hours in a child who's got a fever. What we would think that the child might have meningitis. And when we're thinking about the management of children with meningitis, then you need to think about, firstly, what's called the primary brain injury, like the infection itself, and what might be secondary brain injuries that we can try to avoid. Okay, so the primary brain injury occurs because of the infection, and that occurs when a child's got meningitis like this child did. You can get an inflammation not only around the brain, like of the coverings of the brain, the meninges, but also an inflammation of the brain itself. And we see this often in children, especially young children who have meningitis, that they have both a meningitis and an encephalitis, encephalitis being an infection or inflammation of the brain. So, and that can cause problems for the brain in several ways. The inflammation can lead to areas of lack of oxygen to the brain, or ischemia, lack of blood flow to the brain, or even infarction where certain parts of the brain, the cells have died. So when we think about meningitis, don't just think about an inflammation of the coverings of the brain, but sometimes, often actually, an inflammation affecting the brain as well. And we can help the child who's got meningitis by avoiding secondary brain injury. In fact, that's when we are managing meningitis, apart from giving the right antibiotics and doing some other things right, we need to avoid secondary brain injury. And that's where having an intensive approach can do that. So if a child with meningitis or any other brain injury has hypotension, their blood pressure's low, or they're in shock, or they've got hypoxia, or they've got hypoglycemia, or their hypercarbia, their carbon dioxide level is high, or they've got ongoing seizures, or they've got cerebral edema, or they've got hyponatremia, which just leads to cerebral edema, then they can develop secondary brain injury. And we might not be able to do much about the primary brain injury, apart from giving antibiotics, but we can do a lot about the prevention of secondary brain injury. And so the management of children with meningitis should be both the giving of antibiotics, but also the management of secondary brain injury. So this child's treatment was oxygen, establishing intravenous access, ceftriaxone for meningitis. And because of inflammation of the brain, then dexamethasone or prednisolone, a steroid, can be of benefit as well. And that many young children like this child, 7 months of age, with pneumococcal meningitis, the most common sort of meningitis, can benefit from having steroids. You only need to give it for 2 or up to 4 days, but using prednisolone or methylprednisolone or dexamethasone is ideal. And what that does, it can reduce the inflammation of the brain, and it can reduce often with pneumococcal meningitis, you get a vasculitis or cerebritis, vasculitis meaning an inflammation of the blood vessels, and that can lead to cerebral infarction. So using dexamethasone or prednisolone can do that. This was another child with pneumococcal meningitis' brain scan, and you can see these areas here that are vasculitis within the brain. Don't worry about that too much, but back on this child, the first child I showed you, he's got, when this is a standard CT scan, he's got very little space around his brain, and it tells you that his brain is swollen. And children who have pneumococcal meningitis, Streptococcus pneumonia, often have this degree of cerebritis or inflammation of the brain itself with cerebral edema. And our treatment really should be trying to avoid that, about how to avoid secondary brain injury. And that involves, avoiding secondary brain injury involves doing basic things that improve neuroprotection, the brain, protecting the brain until the infection has had time to resolve. And so we can protect the brain by having the child 30 degrees head up. That's not sitting upright, but sitting upright at 30 degrees. That can reduce the degree of cerebral edema and cerebral swelling, brain swelling that the child might have. We can make sure the child's got an adequate airway so that they don't get airway obstruction and get hypercarbia or hypoxia. We can make sure that they've got adequate oxygenation and ventilation. That is, they're breathing, they're taking good enough breaths. And some children with meningitis will have periods of apnea, or they'll have periods where they're breathing slowly, or they may have periods where their breathing pauses. And that may be because if they're given sedative agents like diazepam or phenobarbital, something that might slow their breathing down. So you need to watch that very carefully. And that's why these children should be managed in an area of the ward where they can be very closely monitored. This child's had very impaired circulation, so cold hands, poor pulses, prolonged capillary refill, and a low blood pressure. And when you've got that, you know that the blood flow to the brain is not going to be adequate. And when you see a child who's got meningitis, then you can fairly safely assume that their intracranial pressure is a bit high. It may not be very high, but it's usually a bit high. Now, our normal intracranial pressure is about 5 to 10 centimeters of water. And if you've got a child's got meningitis, then often their intracranial pressure is about 20. So to overcome that, they need a blood pressure that's a bit higher than normal. All right. So the normal blood pressure for a child of 7 months is at least 65 millimeters of mercury, the systolic blood pressure. But we should be aiming for a bit higher than that in this child. So if you assume that the child's intracranial pressure is 20, then you should have what we call a cerebral perfusion pressure. That is the pressure above that where that allows blood to get to the brain. The cerebral perfusion pressure is the blood pressure minus the intracranial pressure. We can assume that that should be about 60. And so that's the mean blood pressure, the mean blood pressure, right? And so you need to then achieve a blood pressure in this child of about 80/40 to give a cerebral perfusion pressure of about 40, which is a safe cerebral perfusion pressure in a child who's got meningitis. So often we don't think about this too much because we don't measure blood pressure so often. But if you do measure blood pressure, when you see a child like this, it's a good idea to measure their blood pressure and then think about how to achieve a blood pressure that's within the normal range or a bit higher, because they'll need it to keep their brain perfused. Otherwise, they'll get cerebral infarction. In these children, we need to avoid fluid overload. So you should only give isotonic fluid. You shouldn't give 4.3% dextrose and 1/5 normal saline, because there's not enough sodium in that, and that can lead to hyponatremia, and it can lead therefore to cerebral edema. So we should be very aware of that and give isotonic fluids such as normal saline with 5% dextrose or Hartmann's solution, or even giving very little fluid at all, giving very little intravenous fluid, and giving some enteral nasogastric feeding. These children always need an IV intravenous drip to start with anyway for the first few days before they improve, but try not to run too much fluid, and the fluid that you run should always be isotonic. And you should check the sodium at least most days. You should check it if they're on mostly intravenous fluids, and they need anticonvulsants to try to prevent having seizures, which this child obviously did. So they're the basic things you can do for neuroprotection of a child, and they're all designed to prevent secondary brain injury. Okay. We haven't talked too much about blood pressure, but I want you to just have a look at this. This is a chart of normal vital signs. So normal blood pressure, the normal systolic blood pressure for a child is a minimum of 50. And for a baby who's 7 months of age, so somewhere between 60 and 65, that's the minimum systolic blood pressure. and so if you're trying to achieve a slightly higher blood pressure, that's why I said the systolic blood pressure should be about 80, and that will give you a mean blood pressure of about 60, and that will therefore give you a cerebral perfusion pressure of about 40. And in a child of about 1 year of age, you should be trying to achieve a cerebral perfusion pressure of about 40 in a child with meningitis. Okay, so that's a child with meningitis. I wanted to cover that condition first, because I think we often think the management of meningitis is just to give ceftriaxone and then wait and see what happens. But there are some other basic things we can do that can reduce the risk of secondary brain injury, and they can all be done in the wards in which we work. Okay. Now, I'm going to talk about a different case now. A child this was a 5-year-old boy who had 3 weeks of cough and wheeze, a relatively common condition, isn't it? A 5-year-old boy gets cough and wheeze for 3 weeks. And when you hear that story, then what sorts of diagnoses would you think of? I want you to tell me some diagnoses which might cause cough and wheeze for 3 weeks.
Maybe if the child had a background congenital heart disease with now pneumonia on board. Yes,
that's a good thought. So it's possible the child had congenital heart disease and it wasn't picked up or was known about, and then they got a respiratory infection. And I guess that sometimes we think that wheeze is only because of airflow obstruction, but that can happen with congenital heart disease, can't it? And it happens because if there's pulmonary congestion, that is, there's increased lung water, then also you get congestion of the airways, and that can cause wheeze. And it can cause cough, isn't it? So we all know that elderly person who's got heart failure, who has cough and often wheeze, sometimes that can be due to heart disease or heart failure. So that, yes, that's certainly a possibility, the congenital heart disease. I think you also said, Ernie, you said that maybe a foreign body, and that could occur, isn't it? It could cause 3 weeks of cough and wheeze. Can anyone think of any other conditions that might cause, what would be the most common reason why a child might have cough and wheeze for 3 weeks, do you think?
Can the child have tuberculosis, 3 weeks of coughing?
Yes, Arthur, that's a good thought, isn't it? And how can a child have wheeze with tuberculosis? Like, what's the mechanism? There's a common mechanism by which children can have wheeze from tuberculosis.
If the child has got a paratracheal lymphadenopathy, that's they could have wheeze.
That's right, Andre. Yeah, if the child's got perihilar lymphadenopathy that's obstructing either the trachea or the main bronchi, and if the TB lymphadenopathy is large enough, then they can obstruct the bronchi and can cause wheeze. Exactly right. This child, anything else that might cause cough and wheeze for 3 weeks? There's some other common conditions. You should always think of the common things first, and then you should think of the uncommon things. So we've thought about congenital heart disease, and we've thought about a foreign body. We've thought about tuberculosis. What else?
Asthma?
Yeah, good. Asthma. Yeah, very good. I mean, that would be the most common probably cause of cough and wheeze in a 5-year-old for 3 weeks. And so good to think about common things and then think about the rarer things. There's something else that's relatively common at the moment that can cause cough and wheeze for 3 weeks. What is that? What sorts of things can do that? Can you think of anything else?
If they have pertussis,
What's that, Andre? Sorry, you faded out. Say it once more.
I'm saying if they have pertussis, they can be coughing for this.
Pertussis, yes, yeah,
The
pertussis.
whooping cough.
Yeah, that's true. I mean, when you think about prolonged coughing, then whooping cough can do it. Tuberculosis can do it in terms of infections. Whooping cough, tuberculosis. There's another infection in 5-year-old children that could do it. Does anyone know what that is?
The rheumatic heart disease.
Yes, good. Rheumatic heart disease, perhaps causing
And then heart failure now, then cannot lie down.
That's true, yeah. So this child can't lie down without coughing and becoming distressed. So the point about asking you to come up with a differential diagnosis in this syndrome is that it's common, isn't it, to see a child with a few weeks of cough and wheeze, and it might be that it's something common like asthma, or it's or like tuberculosis, or an inhaled foreign body. Or the other thing I'm seeing quite a bit of is children post-COVID. So they might have had COVID a few weeks ago, but still they've got cough and wheeze. And the same post-RSV, the respiratory syncytial virus infection, when children, especially older children, are getting this, they can have often cough and wheeze for quite some time. So what I wanted you to do is think broadly about the differential diagnosis of this, and then you can go into a more detailed history, or you can do a more detailed examination, or take some x-rays and see what's going on. So yeah, okay. On examination, this child was quite pale, and a key part of the story was he was unable to lie down. And as I said, he was unable to lie down without being quite distressed and coughing. And as someone mentioned, it might be an indication of heart failure, but there could be some other things that might make the child unable to lie down and have cough and wheeze for 3 weeks. I'm sorry, Naomi, I missed that. Can you say that again? Yeah, I'm sorry, I didn't get what you said, but yeah. Okay, anyway, this child couldn't lie down. He was comfortable sitting up. If you set him up, he was quite settled, but if you tried to lie him down, he was very uncomfortable. He looked quite pale, and he had moderate intercostal recession. Now, if you see a 5-year-old child with intercostal recession, that's a bit different to a 7-month-old child with intercostal recession, isn't it? Because 5-year-old children with intercostal recession, 5-year-old children have a more stiffer rib cage. And so for them to get intercostal recession, they've got to have quite severe obstruction to their airways. Whereas young children, if they get any degree of respiratory distress, often have some intercostal recession. So the point being, when you're examining a child for signs of respiratory distress, the significance of them differ with age. This boy also had a mild stridor. What does the stridor tell you?
Upper airway obstruction.
Very good, Ernestine. Yeah, it means that the airway obstruction is more upper airway than lower airway, or at least even if it is lower airway, it's also in the upper airway. That's quite right. And you can get stridor from anything that causes an obstruction to the trachea or above, right? The trachea, the larynx, etc. above. But if you have obstruction below the trachea, then you'll get wheeze. So this boy had both wheeze and stridor, and yeah, as I say, he was quite comfortable sitting up, but couldn't lie flat. When examined, he had no lymphadenopathy in his neck or anything. He had a spleen that was 2 centimeters below the left costal margin. Not too concerning. Sorry. And this was his full blood count. So when you're looking at a full blood count, you should always look to see if there's anything abnormal, anything that might suggest a bacterial infection. And the only things that are abnormal here is that his MCV is low. What does that usually suggest? We're used to looking at full blood counts, and we usually just have a look at the hemoglobin, but we often don't look at all the details. So I want you to be able to look at all the details and see what other subtle things that are there. If the NCV is very low, what does that suggest? Andre?
He's got microcytosis.
Yes, good. He's got microcytosis.
The hematocrit is very low as well.
Yes.
It's not very low, but it's low.
Yeah.
Less than 45. So,
yes, that's right.
and the RDW is high.
Yes.
So yeah, it's iron deficiency.
Yes, it looks like he's got
iron deficiency.
Yes. Very good. It looks like he's got iron deficiency. Do you think iron deficiency would explain his symptoms?
The hemoglobin is not very, very low, so it won't.
I agree.
It won't
it doesn't explain why he'd have
got a hemoglobin of 1, then.
Yeah. I agree. It doesn't explain why he'd have 3 weeks of cough and wheeze, but it's so common that I think when we're looking at full blood counts, we need to be trying to identify when there's some other abnormality that might be a related problem. So you notice also that his white cell count's not very high, 6.3. That's not high, and his neutrophil count is okay, but his lymphocyte count was quite low. So again, something that's very common if you see children with respiratory infections of any sort, then often their lymphocyte count can be low, and it may or may not indicate something very serious going on, but just note it. Sometimes it can indicate, for example, the child's got an immunodeficiency, but sometimes it can just be related to virus infections. So just note it and then consider it in the overall assessment of the child. So we've thought already about the differential diagnosis of cough and wheeze, and I think we've come up with almost all of these things. Could it be asthma? Could it be recurrent viral respiratory tract infections, or even just having one episode of COVID, lower respiratory infection can be followed by several weeks of coughing and wheezing, and the same for RSV. Could it be pneumonia, like we said, tuberculosis, or an atypical pneumonia like mycoplasma? That was the other one I was getting at, a 5-year-old child who has 3 weeks of cough. Well, it could be pertussis, or it could be mycoplasma, or it could be tuberculosis. So it's good to think broadly about these things. It could be cardiac, as people mentioned, either unrecognized congenital heart disease or rheumatic heart disease because the child can't lie down, or it could be tuberculosis, like a lymph causing a perihilar lymph node obstruction of the airways of the bronchi, or it could be an inhaled foreign body. These are all possibilities. This was his chest X-ray. What do you see?
It's got bilateral paratracheal lymphadenopathy.
Yes.
And also it's got consolidation. So bilaterally upper to lower, and right upper to lower zone.
Yes,
it could be a malignancy, it could be TB.
Yes, very good. You'd be worried when you saw this X-ray that it doesn't quite look like infection, does it? It looks just a bit unusual for infection. Even if you've got TB, perihilar lymphadenopathy or paratracheal lymphadenopathy, it doesn't quite look like this. And this looks like there's what we say a widened mediastinum, and it's all homogeneously opaque, isn't it? And then there's these other areas here All right, and that you might say, well, that could be infection, but it just looks a bit strange for infection, doesn't it? We don't usually see pneumonia looking like this because the rest of his lung fields look quite normal, right? In fact, you can see the right hemidiaphragm, the left hemidiaphragm, the lung fields look reasonably clear, but there's this more opaque opacity in centrally in the mediastinum, and then there's these other things. What do you think it might be, Andre?
Well, I'm thinking malignancy, most likely.
Yes.
Lymphoma.
And what sort of malignancy do you think it might be?
Infection.
Say that again.
Lymphoma.
Yes, very good. Yes.
Lymphoma.
That's right. Yeah, exactly right. So it's probably not leukemia, is it? Because his white cell count on his blood film was normal. It's not very high, but it could be a lymphoma. Yeah, that's right. And so this child had a lymphoma, and the lymphoma was obstructing his airways. And you can get this with the mediastinal mass. It's relatively common in children, either with a T-cell lymphoma or with Hodgkin's disease. But the point is, if you see a child who's got cough and wheeze in for a prolonged time, then think of the more common things first, okay? Think of asthma or, recurrent respiratory infections or chronic pneumonia or TB. Of course, think of them, but also think that there is a number of children who have mediastinal masses causing the same symptoms, and so get a chest X-ray and have a look. So this boy went on to have a CT scan, and he had a lateral chest X-ray too, and you can see also these areas are large lymph nodes. They're sort of larger than what you'd expect to see in a child with TB. So you might think, well, paratracheal and perihilar lymphadenopathy could be TB, but it doesn't look like the rest of his lungs have got TB. It doesn't look like any major consolidation or anything. So these are very, very big lymph nodes, and they're surrounding the bronchi. When you've got lymph nodes like this, they can cause obstruction to the bronchi and cause quite marked wheeze. This was his CT scan. It doesn't really tell you much that's not evident on the CT scan, but you can see the big lymph nodes there, very large lymph nodes encasing the airways. Right? And you can see here how the airways are actually blocked. They narrow down because of the lymph nodes. Now, the way to make a diagnosis of the type of condition this boy had is to do a lymph node biopsy. And I know you're used to doing fine needle aspirates and biopsies of children who've got TB, and usually you'd biopsy a groin node or a neck node. And I wanted to just cover off how you would do this in this particular child. If you've got a child who's got a mediastinal mass, it's very important that it's done without the child lying down. If you lie this child down, he'll get obstruction, and he'll get obstruction because when the mass will just rest back on his airways, and it will cause obstruction. So you need to do it with the child sitting up, and you can give a bit of ketamine or a very small dose of morphine just to settle him down. You can use a local anesthetic into the area. If there's a node in the neck, for example, this is how this boy was. I biopsied the node in his neck, and you can do it just with him sitting up and semi-awake. The main thing is don't lie the child flat, and you can calm the child down. This 5-year-old boy was able to sit there and just relax with a little bit of morphine and a bit of ketamine and just the tiniest of doses. And with an ultrasound, if you put the ultrasound probe there, you can just aspirate with a needle into the node. And you can see here, this is the lymph node in the boy's neck. Remember, you're not going into the chest, you're only going into the nodes that are evident. And this is the lymph node, the black part, right? And this is the needle going in. And you can see how you just put the ultrasound probe on, so we'll see clearly the lymph node. Now, of course, this is ideally best done in the operating theatre if you've got an operating room, but you know, it can be done fairly simply if you are very careful not to lie the child down, and have other safety measures there, have oxygen and suction, and make sure you've got somebody else who's skilled in giving basic anesthetics or sedation who can give the ketamine, etc. All right. So that's that child who I just wanted to mostly talk about chronic cough and wheeze. And if you think about the common conditions first before you think about the rare conditions. All right. We've got a bit more time, so I'm going to talk about this next child, a 2-year-old boy with coughing and severe respiratory distress. Now, this was a boy who had a runny nose and fever for about 3 days, and then he had a coughing fit while eating breakfast, and he was eating porridge, so he's eating oats. His mother then slapped him on the back, and he improved. He became was breathing again okay, but then throughout the day he got worsening respiratory distress. And when he presented, he had a respiratory rate of 66. He had chest indrawing, crepitations on the right side, a heart rate that was high, an oxygen saturation that was low, and wheezing over the right side of the lung. So what would, when you hear this story, what would you think might be happening?
He could have aspirated.
Yes, that's right. He could have aspirated the oats he was eating, and that might have caused him to have pneumonia or wheeze related to that. So sometimes, if children are at risk of having wheeze because they have an underlying risk of asthma, then if they aspirate anything, no matter what it is, whether it's just some dirt particles or some dust particles or food particles, they can have more wheeze. So it could be that he had pneumonia or he had asthma, or he could have had a foreign body aspiration, and it seemed to start his coughing fits when he was eating these oats. So when the point I wanted to make was, if you think a child might have a foreign body aspiration, then it's useful to take a chest X-ray, but it's useful to take a chest X-ray in a special way. Right? Does anyone know how ideally you take a chest X-ray of a child that you think has got a foreign body aspiration? How would you do it? Well, ideally you take it with the child taking a big breath in and a big breath out, right? And breathing all the way out. And the reason why you take it like that is when the child takes a big breath in, then both lungs will expand. When the child breathes out, then the lung that's affected by the foreign body will often remain expanded, whereas the lung that's not affected by the foreign body will often collapse normally or come back to the normal size. And that's because there often is a ball valve obstruction to one of the bronchi when if a child aspirates food particles or something like that. Okay, so you take an X-ray when the child's taking a big breath in or breathing out. Now that's fine if you've got a child who's 5 years of age or 10, they can cooperate with you. But if you don't have that, if you've got a young child who's only 2 and has got frequent coughing and is hard to ask to do anything, then the way to do it is to take an X-ray with the child lying on the left side down and then on the right side down. And I'll just show you what this child's X-rays look like, because what you're looking for is a difference in the inflation from one side to the other. All right, so this is the child with the left side up, right? So right side down. And you can see, if you looked at this X-ray, the one on the left, you would say it looks pretty normal. I don't think you can see much difference between the two. From the left lung, looks pretty much the same as the right lung, and there's no pneumonia. But when you lay the child down on the right side, you can see there is a difference. I hope you can see this. And it looks like the left lung is relatively smaller. The child's breathed out. but the child breathed out, and the right lung looks so much larger and looks so much more translucent. And that's a sign that there could be a foreign body down the right main bronchus, or there could be some obstruction to the right main bronchus, right? It could be TB lymph nodes, for example, obstructing the right main bronchus, leading to that, what we call a differential inflation of the lungs. That is, one side is more over-distended than the other side. And this is a relatively common thing we see, I think, in pediatrics use. So it's good to look for differences in the inflation of one lung versus the other lung. And these are the same x-rays, but I've just put them around the other way. You can see there's not much difference when the child was left side down, but when the child was right side up, then there was a big difference. That is, the right lung was very distended and the left lung was down. So this child actually had a foreign body down the right main bronchus, and it was able to be removed with a bronchoscopy. You can actually see, if you look down the trachea here, you can see the left main bronchus coming off the trachea, but the right one looks like it stops a bit, doesn't it? And that's because there's something blocking the right main bronchus. Right? This child had the foreign body removed at bronchoscopy, and there was multiple food particles down the right main bronchus, and then he just needed oxygen for a few days and penicillin for 7 days, and he recovered fine. So the point of that is that when you see your child who you think has might have an inhaled foreign body, you can do something about it. You can make the diagnosis by the clinical signs, the asymmetry of wheeze or the asymmetry of chest signs, with the history, with an X-ray taken in a special way. Right? This is another child who had, again, it looks like a pneumothorax, doesn't it? You can see how black this lung is, how black the lung is relative to the other side. And this was an expiratory film, so that asked the child to inspire, take a big breath, and then expire. And the left lung is normally deflated, but the right lung remains inflated. And again, there's a foreign body down the right main bronchus. And this was a coffee bean. The child choked on a coffee bean and had massive over-distension of that lung. Right? This is another child I saw actually just this week, and I thought it was useful in using the same principles. Just look at the X-ray on the left. What do you actually see? Can someone suggest what you see? There's two things that are on the X-ray that are worth noting. Can anyone see anything? Well, firstly, when you're looking at an X-ray, so we normally describe the heart, we normally describe the hemidiaphragm, the lungs. So I would normally say that the heart size looks normal. There doesn't seem to be any enlargement of the heart. You can see the left hemidiaphragm well. You can see the right hemidiaphragm well. The lung fields look quite clear. In fact, the left one looks a bit blacker than the right lung. And the child looks like he's got a nasogastric tube in, doesn't it? The nasogastric tube is there. But there's something a bit odd about the nasogastric tube that I thought you might pick up on. What is that? What's odd about it is it doesn't go in a straight line. It seems to take a deviation in the mid-trachea or the mid-mediastinum, and the trachea also doesn't take a straight line. It also goes off in the same direction as the nasogastric tube, which is a bit odd. And that was the X-ray back in June, and this is the X-ray just this week. And you can see there's been a progression of it. Still, the nasogastric tube is a bit pushed over to one side, but now the left lung is very dilated, isn't it? Very distended, and the right lung is quite collapsed. So this is the same. What I'm describing is the same phenomenon, the same problem of having something obstructing this time the left main bronchus, because it's the left lung that's very dilated. And when you've got if you've got an inhaled foreign body, usually it's the right main bronchus that's obstructed. So the right lung would be larger, not always, but usually. So, and this child's got, when the child went home and didn't have a nasogastric tube for most of these few months, but now has a nasogastric tube that's very deviated. So it makes you think that there might be something sitting here blocking the left main bronchus, right? And so that's indeed what he had. He had a large cyst in this area, blocking the left main bronchus, causing obstruction, causing the lung to distend. So the main message is that when we see asymmetry on a chest X-ray, we should have to try to explain it. All right, you should try to explain why there is asymmetry. And even back in June, you could see this child had asymmetry with a blacker left lung than the right lung, and this odd deviation to the nasogastric tube. So we probably should have been able to explain it then, what might be the problem. This boy went on to have a CT scan. I won't go through this too much with you, but you can see this round cyst-like opacity here. This is the heart. This is the pulmonary artery, the aorta. This is the normal heart, but there's something sitting behind it, pushing it all forward, and that's this cyst that's just here. So the child's got a cyst that's blocking the main airway. This is the airway, and it's just blocking that and causing the left lung to be over distended. Okay, all right. Look, so today we've just covered off a number of cases that I thought were useful. There's one more that I've got to talk about, and I might go on with that if that's all right. This was a 7-year-old boy who presented with diarrhea and vomiting, and so a different sort of presentation. We've talked about neuro presentations, meningitis. We've talked about respiratory distress, and now this is a child who had diarrhea and vomiting. And he'd had 2 days of diarrhea and vomiting, and then a large bout of diarrhea, and then he'd collapsed. And when he presented, his blood pressure was 52/18 with a mean of 40. Now, if you remember what I said about normal values, normal blood pressures, you'll remember that that's very low for a child of 7. Let's go back to what we said about the normal values. And a 7-year-old, so he should have a normal blood pressure somewhere between 75 and 80, but this child's blood pressure was only 50, so that's very low, right? Yep. So his blood pressure was 52/18 with a mean of 40. His pulses were weak and his heart rate was 170, and he looked pale and mottled. So the question is, does he have any emergency signs, and what emergency treatment would you give?
Yes, he has signs of shock, so
Yes.
we should he has emergency signs. We should try to resuscitate him with fluids.
Yes. What would you do, Benji? What in terms of resuscitation? What would you do?
Put in a cannula and try to run some fluids.
Yes. And how much fluid would you give? Just roughly speaking.
20 mils per kg.
Yeah, that's right. A child like this who's got weak pulses, marked tachycardia, and a very low blood pressure for his age, you would give 20 mils per kilo of fluid. Because he's got diarrhea and vomiting, you can't do any harm by doing that. If a child presents though with sepsis and pneumonia, then you can make things worse if you give them lots of fluid. But in a child who's got diarrhea and vomiting and signs of shock from hypovolemia or severe dehydration, then you can hardly do any harm. So yes, that would be a good first up emergency treatment. This boy had a a history of Hirschsprung's disease. So again, after you've done emergency signs and emergency treatment, you need to take a more detailed history. And he had a history of Hirschsprung's disease. This was his X-ray. What can you see?
Obvious dilatation of the gut, gaseous distension.
Yes, that's right. There's marked distension of bowel, isn't there? This boy had a removal of some of his colon when he was a small baby as a treatment for his Hirschsprung's disease, and mostly he'd been quite well up until he got sick this time. But you can see how dilated his bowel is, and this is, we've just measured it here, 9 centimeters across his large descending colon, but the other areas of his bowel are quite large. Well, can you think of a condition that might cause this?
Intussusception or bowel obstruction.
Yeah, he could have a bowel obstruction, except that he'd had vomiting and diarrhea, isn't it? So when a child's got vomiting and diarrhea, then you need to think of it could be a bowel obstruction, but not very likely, eh?
Yeah, volvulus.
What's that? Sorry.
Megalocolon.
Yes, someone said megalocolon, which is another. Yes. Toxic megacolon is a term that is often applied, a toxic megacolon. And children, the point about talking about this case is that children who've had Hirschsprung's disease can get this condition, which is called a toxic megacolon, where their bowel becomes very dilated, where they have diarrhea. It's usually related to an infection, but it's called Hershbrongs Enterocolitis. And it's usually related to a bowel infection. So this boy had Hirschsprung's enterocolitis or toxic megacolon. He'd had a history of Hirschsprung's disease from birth, and as I said, he'd had a resection of the large bowel, just the descending colon, and then it was reanastomosed. So he'd had quite a good operation that for 6 years had done him very well, and he'd been growing well, and he was now 25 kilos. And this was his blood gas when he came in. I just want you to try to interpret this blood gas. What do you think it means?
So the HP is 6.77. So but the base excess is -29. So there could be some compensation, like a metabolic acidosis with some compensation.
That's right, Benji. So his bicarbonate is only 8, isn't it? First of all, he's got a severe acidosis. And you can say it's a metabolic acidosis primarily, isn't it? Because his bicarbonate is 8. His carbon dioxide level is a bit high, but not very high. It's probably a bit high because he's got such a distended abdomen, yeah? And his base excess is very low. So he's got a partially... he's got uncompensated metabolic acidosis. What do you think about his hemoglobin level? What do you think that means?
Polycythemic.
Yes, why is he polycythemic, Benji? Why do you think?
Yeah, he's just got severe dehydration, that's why.
Very good, Andre. Yeah, it's because he's got severe dehydration. I want you to again look in detail at these investigations, because they all tell a bit of a story. They can all give you a clue as to what's going on. So he's got severe dehydration, he's got severe metabolic acidosis, and when you look at blood gases and see what sometimes you can see the glucose and sometimes you can see the lactate. What do you think about the glucose? Has anyone got a comment about the glucose? Why might the glucose be 14? it's quite common actually that we always look for hypoglycemia, but in children who are critically unwell, often they may have hypoglycemia, but they might also have hyperglycemia. And there's a good reason for this. Why is that? Often it's because of a severe stress response. You know, they have a lot of, if you've got shock because of hypovolemia, because you've had so much vomiting and diarrhea, then you'll often have a lot of circulating catecholamines and cortisol, and they cause the blood pressure to go up, the blood glucose to go up, and it's part of the stress response. Now, of course, the children can be hypoglycemic, but when you see hyperglycemia in this sort of setting, then think that maybe they've got a severe stress response. The lactate of 14 just gives you an indication of how hypovolemic this child is, how much in shock the child is. We've covered off most of those things. The hemoglobin tells you about how dehydrated the child is in this circumstance. The metabolic acidosis suggests that the child's very dehydrated. The lactate is high, suggesting shock, and the glucose is high, suggesting a severe stress response in the child. Right, so when you're thinking about the differential diagnosis of severe dehydration and shock from vomiting and diarrhea, then of course you can get it from just viral diarrhea, from rotavirus or adenovirus or norovirus. They can all cause severe dehydration and shock also. Or it can happen because of dysentery from E. coli or Shigella, or it can be from cholera. So all these infectious diarrheas. And sometimes it can happen because of antibiotic-associated diarrhea, like Clostridium difficile. But in this case, the child had Hirschsprung's disease. And so this is a Hirschsprung's Enterocolitis, or as I think Andre said, a toxic megacolon. And the treatment for the a toxic megacolon is like an inflammatory colitis, a bit like pig bell or necrotizing enterocolitis. Sometimes it's because of Clostridium infection. And the children present with severe lethargy and fever and diarrhea and bloody stools, just like as if they had pig bell. They usually have severe shock from dehydration, but also from toxic shock from the bacterial infection as well. So the treatment for this is rehydration. So the rehydration for severe dehydration. I just want to go through a couple of things about how you calculate the rehydration fluids. So this child received 20 mils per kilo, like Benji said, twice in the emergency department, but was still severely dehydrated. So when you think about that, a 25 kilo child who's 10% dehydrated will be have a big deficit. So you need to think about the fluid replacement being the maintenance plus the deficit plus the replacement for ongoing losses. And this child's maintenance would be 100 mils per kilo for the first 10 kilos. Remember, this is the 150-20 rule, 100 mils per kilo for the first 10 kilos, 50 mils per kilo for the next 10 kilos, and 20 mils per kilo thereafter. And if you work that out, it's 1,600 mils over 24 hours, or 67 mils per hour if you divide it by 24. Now, we'd probably want to replace the deficit in 12 hours, 8 to 12 hours. And this child's deficit, 10% of 25 kilos is 2.5 liters, or 2,500 mils. So if you divide that by 12, because you want to replace it in 12 hours, then that's 208 mils per hour. So 208 plus 67 is about 275. Okay, and we wouldn't normally run fluids being that high, but that's why you need to calculate it specifically for that child and think, well, seems a large amount of fluid, but this is what he needs to rehydrate him. And you'd add on about 100 mils for every diarrheal stool he had. So if he has more diarrhea, then you've got to add an extra 100 mils in your calculation. So it ends up being a very large volumes of fluid for children who are severely dehydrated, especially if they're older children. And we're not used to giving that much fluid, but that's what you need to do. The treatment for Hirschsprung's enterocolitis is antibiotics, so amoxicillin, gentamicin, and metronidazole, all covering the bowel pathogens. These children usually need a sort of a bowel washout. So you pass a rectal tube and you wash it out with normal saline, just saline irrigation of their bowel. And this child recovered very well in 5 days with all of that treatment. So simple things. It didn't need much: antibiotics, fluids, irrigation of his bowel. And you can do that with just, again, giving a small dose of ketamine and doing it every time. We did this each day, to begin with, twice a day. We washed out his bowel, and that worked very well. And he recovered well within 5 days. Okay, so what we've learned today, we've covered a lot of cases, and we've talked about neuroprotection for meningitis, and we've talked about the way we can prevent secondary brain injury. We've talked about the causes of wheeze and respiratory distress. We've talked about how to do a procedure in a child who can't lie flat, has got a mediastinal mass. We talked about the X-ray changes of an inhaled foreign body, and we've talked about Hershbrongs Enterocolitis or toxic megacolon, and how to assess and manage dehydration. So these are all basic things: neurological, respiratory, gastrointestinal things that we can do in cases that we see. Right. And last week I talked about having a way to assess children each day when you see them, if they're critically ill, on the ward round. And I try to have this approach in my head. I don't follow the A, B, C, D all the time, but if you have this approach in your head, then you don't miss anything. So you think about the child's airway. Is there stridor or upper airway obstruction? You think about their breathing, their respiratory rate, their signs of respiratory distress, their oxygen saturation. Some people use a respiratory distress score. Think about their circulation, all the things I mentioned before about feeling the hands and feet, and making a careful assessment of that. Think about their neurological condition, their response to pain, their Glasgow Coma score, depending on what the problem is. For D, also review all their drugs, check the doses, decide which drugs are no longer needed, you can stop today. E is for exposure, so think about their temperature. When children are in critically ill, they often have lots of other cannula, like IV cannula, or they might have a nasogastric tube, and you should think, is each of these things necessary today? Think about their electrolytes and their creatininuria, and then think about their fluids and feeding, the F. Think about their glucose, if their blood sugar is normal, and think about whether or not you're giving enough feed to ensure the child's not hypoglycemic. For H, think about the hematology, check for anemia, their full blood count. Just look for all the signs of infection on their full blood count. And for I, think about the clinical signs of infection, because we really want to stop cross-infection in patients. So it's not a whole alphabet, but it helps me just not forget things when I see children like this. And maybe it'll help you as well. All right, well, look, that's all I wanted to say today. We've covered a lot of ground. I will send around the slides and also the link to the presentation. But I hope that's been useful in